Microphone check. Test 1, 2.
Okay. Good morning, everyone. Let's go ahead and call to order the Finance Planning and Investment Committee meeting for November the 16th. All right, hi. DT is enjoying himself in Paris, so I'm not talking to him until he didn't invite me, so I'm not talking to him. Okay, the first on our agenda is approval of the minutes. Are there any corrections to the October 16 minutes? There being no corrections, I'll entertain a motion for approval. All right, it's been moved by Ralph, second by Zim. All those in favor of approval of the minutes signify by saying aye. Aye. Those that oppose by nay. Motion passes unanimous. We will just follow our agenda for planning. I think that whole agenda is Adam.
So just some quick updates on the construction that's going on the PEC. These pictures, of course, were filed earlier with this before the pour that occurred earlier this week. So the entire parking area to the north by the breezeway is complete. We've done some testing for the fire system that was buried underground. And in fact, that was very successful. So now we can shut that off and build the drive, and the new drive that will lead into the PEC will be poured shortly. Of course, we have some drizzle today, but that's going to postpone us a few days. But they are drilling piers, and if when you drive out today, you will see they have heavy rigs out there right now lifting all the structural cages and putting them in the piers, the pier holes. So we're moving along nicely on the PEC, and I'm very happy with that project so far. Next is the temporary parking. Temporary parking, of course, Lot A is occupied fully. Lot B, where the eligibility center was and is no more, is a very large pile of dirt that's moving forward quickly, and Lot D and E are scheduled to open the first week of December. Those are the lots north of Rosedale, and Lot C will follow up after the beginning of the year. So our temporary parking is coming along very nicely, and we are looking for additional parking to rent spaces, and we're seeing unprecedented volumes, and so we probably will rent some spaces with one of the churches for day shift somewhere in the area. But we are seeing significant volumes, well past what was projected by our parking consultants. So that is making us think again about parking.
Okay.
Medical Home Southwest, this has moved much farther than the pictures. In fact, they've started to erect steel. They are actually laying in beams across all the columns, so pretty soon they will be laying all the roof trusses in for that project. So it is moving along very quickly. It's amazing what happens once you get out of the dirt and you're not in the mud and you can actually build something. So it's really nice to see that moving expeditiously. Lastly, this was something that Zim and Trent asked for. Trent had the first iteration last month, and we agreed to go ahead and post that this month to the board. This is a cumulative spend of the entire master facility program. The orange bar represents the cash flows on a monthly basis cumulatively across the 10-year schedule of the master plan. The yellow bar that's underneath that is actual spend to date. So we are in a good place. We are still under the orange bar. That's always a good place to be. Don't be surprised occasionally if we peak above that, if we buy a steel package or we buy something down early. So it may temporarily peak above that and then drop back down. But right now we're moving along as the cash flows are predicted. So, and that's great. And then below that, you can see the timeline for the schedules for construction for the temporary parking PEC in Southwest. That bar will continue to grow as projects come online of construction. But in the meantime, it's just the 3 projects currently under construction. And that's the update for this month.
All right.
Any questions? Yes, sir.
Block to the left on the total program cost.
Yes, sir.
That is projected, correct?
Yes, the 1.511 million is the Cummings number, the initial Cummings number for the estimated costs for each of the projects. The projects, some may be more, some may be less, because of course those are estimates, but it's always been projected that would be the max cap for the projects. And then the dollars may shift between the projects themselves within that number.
Good. So as we move along, will we continue to look at that if there needs to be an update?
We are doing so right now. We are in that process with Cummings right now.
I guess I'm just looking at those projects that's down the road.
Yeah, no, I think you make a good point, and we do understand inflation will probably continue, cost of supplies will continue to go up, so we continue to evaluate. We look for opportunities where we may be able to accelerate some projects and bring down that cost in what we're doing now so that we will have what we anticipate will probably be some additional needs of dollars in the future, but we are always working to keep it close to the 1.5.
I really like this. This is good. But is kind of piggyback on the Rev, as you make these changes, I'd like to see where the numbers change on this side too.
We will do that.
Yes, sort of a delta each time that you do
Yes, sir.
that.
We haven't made any yet. We haven't shifted dollars between projects yet, but we do anticipate that. With some of the infrastructure issues that the city is having us consume, that will shift projects specifically. So
No,
when we do that, we'll let you know, of course.
I just think it's helpful to get the visibility each time you do this review. And I don't know that you want to do it maybe once every 6 months. I don't know. That's up to y'all. But when you do it, then we'd like to see the deltas and where they fit on the various projects.
I prefer every month because I don't want to go so far out that you guys are not
I won't
educated
argue
on what
with
we're
you.
doing.
No, I think the monthly is good.
Yeah.
Well, the reason I said maybe a little longer than that is that requires a lot
Take
of
time.
work to do it. And I'm not sure that we need that kind of fidelity. You might for what you're doing, but
Yes, sir.
so. okay.
Certainly, if the number goes above the 1.5 or we accelerate projects, we're going to bring those forward immediately.
No, that number doesn't change.
Yeah. Apparently, the economy's not listening to you.
Okay. I was going to say something, but then I thought better of it.
All right, yeah, that's a good idea. Okay, all right. Anyone else have any
Anything else?
questions of Adam? Well, thanks, Adam. I like the report. It's good. Okay.
Yes, ma'am.
All right. Next, we'll have Stanley, you for the finance.
Good morning.
Morning.
So for the CFO report this morning, Stan is here with me today. We continue to transition. He's been here all of 18 days, I think. So he's a pro. But I think he would agree that as he gets to know us a little better, he gets more confident and comfortable with us. But today I'll be your primary presenter, and he'll kind of weigh in as needed. I would say there's a tremendous amount of stability within the finance team and confidence right now. A lot of change, but that confidence doesn't come from me, but a great team. So I think you are in good hands in the short term. A lot of people have stepped up and made a lot of things happen for the organization. I personally have enjoyed working with the executive team and getting to see how they balance finances and patient care every day. So that's been good for me. Our annual UC and DISH report is being finalized. That's a huge part of our Medicaid supplemental funding. So that will be submitted later this month. And then, of course, our financial audit is being finalized as well. My overall assessment of the month of October was a good month, good start. There's a saying that you can't win the game in the first quarter, but you can lose it. We did not lose it. We did not win it. So, but 1 month does not make a trend. So let's keep that in mind. We do have, major initiatives around access, master facilities planning, workforce, and in particular the labor in terms of the market increases. But I will tell you, we are working hard to find savings, to find initiatives that offset some of those increased costs in our Fit for Growth work and also revenue improvements. There's been a number of revenue improvements that have already come down the first part of this year. So as an organization, I think we've done a much better job this year getting things started and off the ground. And you'll see a tremendous amount of work going on in IT and access, as well as the master facility plan. You're seeing all of that with Adam and his team. So my overall assessment, consolidated results are favorable to, this month to budget. Operating income, $2.8 million. And then net income is $4 million favorable to budget. We're going to look at financials. We're going to go into much greater detail in the slides that come. So let's look at a few statistical indicators. Our admissions were down slightly for the month, but I'll take just a minute to explain observation cases were up. And it's important to kind of combine those together as you look at, if I've never explained or observations never been explained, it's kind of a 23 to 48 hour patient. And sometimes determining the status of whether they belong in that 23 to 48 hours or a longer stay, 4 to 5 days as an inpatient, is where we have fluctuation between inpatient and outpatient. So it's very important to look at that. Although our inpatient admissions are down for the month, we do have about 58 more observation patients for the month. So it kind of balances itself out. We did have a strong month in deliveries and NICU as well. I tried to reconcile that. The only thing I could think of is we had a lot of cold months in January. So when you think about that, we're about 9 months from some very cold months in January. Our emergency visits continue to be higher on reducing left without being seen. We're about 6% over budget on emergency visits. You can see the blue bar, of course, is our current year, and our yellow bar is our prior year, and then the red line, of course, is the budget. Specialty visits, bottom right. That one was high enough I had to do some research. We had some cardiologists, or at least one cardiologist that came on board in March and April. And then they are fully ramped up now. And then we've also done some what they call template work in scheduling in both of our medical specialty clinics, which are in 1350 and 1400 JPOC. So really squeezing more patients into specialty care and lowering the cancellation rate. So Joy and Parker and her team have done a great job really expanding specialty care in the month of October. Had quite a bit more pain management cases in the month. Our surgeries are just very flat to budget, so right on budget. There's a slight decrease in general surgery on the outpatient side. Still looking into that a little bit to see maybe is there a trend there or kind of what's causing that. Because surgeries have been running much higher, but we also budgeted higher based on that, so, okay.
I wanted to just chime in real quick and mention that in terms of the inpatient surgeries, you have it right there that you'll see for quite a few of the major categories, major services, cardiovascular, neurosurgery, and others, urology, just to mention an OB, that we exceeded a budget for the month. So I wanted to point that out. So, yeah.
All right, thank you, Stan. Behavioral continues to be just a trend where we have less emergency visits and more primary, in clinic visits. So that's a good trend, keeping people out of the ED and more in a clinic setting. Other questions? Any questions on the statistics? We want to look back, and is anybody, I'll pause there for a minute.
Or you said you're trying to work to continue to reduce the amount of people leaving the emergency room without being seen. Are we doing that?
Yes.
Okay, that's not in the chart, so I was confused when you.
Last month, we were 1.9%, which is phenomenal. CMS, their standard is 3%.
Okay.
So phenomenal work in our emergency department and really throughout the house from a throughput standpoint.
Okay, great, thank you.
Okay, good question. Anything else? All right, we'll hit the financial metrics. Again, you're very used to seeing the payer mix graph or the color.
I want to ask one more question.
Yeah.
On the behavioral health emergency visits, that's been down the last couple of months or periods. Is there something in the community that's changing that? I mean, I know the need's not going away for behavioral health, but it seems like it's trending down every time we talk about it.
And so we asked that question internally. To your point, we don't think that the need in the community has really gone down. What you do see is that our access in the clinics and the outpatient setting has improved. And so we think that as you improve access in the community where your patients are at, there's less of that comes into your emergency room, whether it be behavioral health or whether it be our medical emergency room. But we'll continue to look at that.
Okay, thank you.
Okay, payer mix, the wonderful color bars that you can't see the numbers on. We need to work on that a little bit, but pretty much the same story as the last few months. Higher commercial mix due to Cigna Marketplace and lower Medicaid. I will tell you, we did budget for a change there. We budgeted, but we're just not seeing that shift yet. I think over time, some of these patients that will get back on Medicaid will raise that Medicaid percentage of payer mix. But honestly, a lot of those people were extended through the pandemic and will never come back onto Medicaid because they're just not eligible. So we may see that Medicaid still running lower than what we had in prior years. We did have a question, I believe, one of the prior meetings about our self-pay and connections. If you look at the prior year, we are within 1/10 of 1 point. So we're just running very steady on self-pay and connections as a percentage of our total payer mix. So that's a good thing. Although we may be losing some Medicaid and gaining some commercial, we're not seeing a huge spike in the uninsured population. So that's a good thing to look at. FTEs per APD, I think we often take for granted that we know what that means. I'll take just a sec to explain that one. If you were to compare FTEs to patient days, you wouldn't account for the entire activity in the hospital. So what we do is we add a factor for outpatient activity, and that helps us compare, be more comparative with inpatient and outpatient activity. So we are under budget there, just slightly, but we are slightly higher than the prior year. A lot of that is due to just lower vacancy. And we also have more FTEs flexing for additional volume. So.
And that also includes contract employees, that's.
Does include, the contract employee number, I think, is about 55, so that's.
Okay.
Yeah. Much lower than it has been. Cash in the bottom left did rebound nicely. I talked a little bit about how we had a lull there in September due to the CHIRP funding increase, so we did see that bounce back, so we were a little over budget on the cash. I did some research in the connections enrollment. We did have a low month, but we have a software database. It's called Verity, and the software was down nearly the entire month, so it really slowed down application processing within our connections patients. It was not on our end. The software glitch was not on our end, so it was on the vendor's end, but I can't speak to the technicality of that. So, questions on financial metrics?
Reason is that
Yeah, we couldn't process applications timely, so it should rebound. We should see that number kind of bounce back up. Yes, sir. All right, let's get to the income statement, and this is where we're probably going to spend a fair amount of time. I do want to point out that we did make a change to move the ad valorem tax revenue below operating income. That's consistent with our audit and how our audit would be stated, but it's also consistent with most, if not all, of the other public hospitals. So it's going to look a little weird, and we may have to kind of painfully get through this together to really understand what the numbers represent. But I'll do my best to kind of help us through that. But let's go to the top first, talk a little about revenue. I mentioned the stronger payer mix, increasing revenue there. So that's where you see the 1.6 million impact. I will point out the $2 million Medicaid supplemental funding adjustment there. We're going to be booking supplemental funding revenue below budget until we get some better information on that. As you know, Congress enacted a $8 billion cut. And our portion of that $8 billion cut, we did budget for, but the formula change in October actually caused us to under budget that impact. So we did the best we could with the information we had at the time, and it really has to do with the way the dollars trickle down from the federal government and how they're distributed. We are getting less of a portion than we expected. And so we are making that adjustment. This is a moving target. There's a bill before Congress right now that would delay the cuts until, I believe, 2026. And then the cuts that was $8 billion over 4 years, which was $32 billion. It would actually cut that in half to $16 billion, from 32 to 16. This is a moving target. So if we see something change in future months, it's because we got better information. So did I totally confuse everyone on that one, or is everybody good? Okay.
Congress might be confused.
They might, if they're there, yeah, they might be confused. So, yeah, correct. Salaries and wages were a little bit over budget. Again, I mentioned that when we flex, we're right on. And flex just means account for additional volume. Contract labor, I just can't say enough. When you look at the trend there, we budgeted 3.7 million, and we came in at really $1 million. That's just amazing work by recruitment as well as nursing. I think our nursing vacancies are extremely low, and so we will see higher wages, but we'll see less contract labor. So
Yeah, I'll chime in on that as well. I dug a little bit deeper on the contract labor piece. Of course, coming in new, you look at what was budgeted and that variance, and I was thinking, well, did we miss some accruals or something? But the team verified that we basically right now really only have about 20, which is amazing to me, about 20 different 20 contract nurses, if you will. So just to Roy's point, I mean, it's just phenomenal work. Yeah.
Yeah, so 2.6 million of that contract labor of the 2.7 is nursing. So that tells you that's what's happened is they've just filled vacancies. So I work on the 4th floor in the JPOC building, and every Monday it's like I can't find my way down the hall. There's so many people going through orientation. So,
Rory,
yes.
question. Is it fair to say that some of the overage in salaries is directly the opposite side of the decrease in contract?
Yes, it's exactly fair to say that. So we should really look at that bottom line salaries and related expenses, kind of really to get a better picture of where we're at. You have to kind of look at the two together. Yeah. Okay, purchase services is where you see the biggest variance on the expense side. That is really just a ramp up of projects. We have, as I mentioned before, we've done a much better job this year of getting things off the ground, but it still has to catch up to, the expenses have to catch up to the work. So I personally have been looking through the IT stuff this month. It's coming in, projects are ramping up, but a lot of times when we approve those things late in the budget cycle, August, September, it takes, some of these have to be RFP'd, they have to actually go through approval processes, so you don't see the impact in the first month. So you'll start to see that pick up. The negative variance on supplies is really drugs. We had 3 areas in the month that were over. The cancer center, we continue to have high-cost drugs in the cancer center, and also specialty pharmacy. That specialty pharmacy is really humming with volume, and so we do have some higher expense in specialty. If you don't know what specialty might mean, that's things that are, for example, Humira. You've heard of Humira for a biologic drug. That would be an example of specialty pharmacy. And then I think we had a little bit of overage in Central Fill as well, the Central Fill pharmacy. So let's get down to kind of the difference here. We are showing you an operating income loss of $38.5 million. That's the change with moving ad valorem below. We budgeted $41.3 million, and so we are better to budget by $2.8 million. That's what I would focus on as a board member, really for the short term. That's how we're outperforming where we budgeted. So the month of October, we're better to budget than what we expected. When you do account for ad valorem, of course, our net income or our bottom line was 14.7 with 8.6 of that being investment income. So we're up again in that in our investment income, about $1 million. So overall, $4 million total. So that's a decent summary of where we're at. The one thing I would try to keep in your head for this year is if we were to restate things, our operating income target would be $29 million. So keep that $29.5 million in your head. That's what we were expecting to do from an operating income standpoint. And that is, by comparison, we budgeted 69 last year. So that helps you kind of relate to what did we budget this year versus what we budgeted last year. Questions? Can I?
Yeah, a couple of comments. First of all, I appreciate the restructuring of the income statement. As a new guy on the board, I'm not used to the old way. So this is the first income statement I've seen since I've been here that looks like an income statement. If you're wanting to kind of relate things back to the past, for the rest of the board that's used to the old way, maybe a statement of cash flows would be a better way to do that than to try to keep lifting up the property taxes above, mentally, so it looked like the past. I think it needs to stay where it is for all discussion purposes. Are we over on investment income because we assumed a lower interest rate on our investments than we maybe should have assumed when we budgeted? When did we do the budget where we came up with that estimate?
Yeah, we rely on Hilltop to kind of budget that number, and I think it was really under budgeted by maybe 0.5%. But when you have $1 billion in investments, a 0.5% is a lot.
A lot of money.
Yeah, so it's really just a little bit of a percent, 0.5% that we budgeted less than what the actual's coming in.
So that's about, what, 1.2 million, about maybe 15 million per year?
Yes.
If interest rates stay level.
Yep. I'll make a note on your cash flow. I did prepare a cash flow statement at year end for September. We don't typically include a cash flow statement in the financial packet, but we can discuss.
That may be a way to reconcile the past with the future.
Okay. Sure. Anything else on the income statement? Okay. Balance sheet, pretty straightforward. The only thing I would keep you updated on is the days cash on hand are currently 207 are the operating days on hand, and then another 148 in the board restricted fund. So that totals 355. As I mentioned earlier, I think it was the last board meeting, we need to close November, the month of November, so that we can come with a recommendation on what we might transfer into the future fund or the board restricted funds for December. We do anticipate we will do that, but we would like to go ahead and get November closed out and make sure we have a better projection on that. So we are putting those funds in like from a type of investment?
Yeah, well, I mean, we've got board restricted for the match facility and we got the bond proceeds, but the next line, or the line above that is restricted investments.
Right. We are putting those in a safe vehicle for investment as a safe.
Restricted investments.
The first one.
Oh, the top line.
Yeah.
I have to get back to you on that one. I'm not sure what's in that restricted investment category.
Okay.
Yeah. I see what you're saying. Took me a minute to catch up to you, Roger.
That's all right. Not many people can ever say that, so it's usually me catching up.
I'll get you an answer
Okay,
on
thanks.
what's restricted in there. Okay. Anything you have?
Just, we went through, obviously, the volume and everything, and just having an opportunity to see it all roll together for the first time and actually go into some of the detail, I think was beneficial. And we'll continue diving in, trying to do a deep dive and absorbing not just the financials, that's reflective of the actual operations themselves, so, yeah.
Are there any other questions? Then I'll entertain a motion to accept the financial report. Okay, is there a second? All those in favor of acceptance of the report signify by saying aye. Those opposed by nay. Motion passes unanimous, okay? Thank you. Thank you, Roy. Thank you for doing the explanations. That's really, I'm grateful to that, okay? It's really good. Thanks. Adam, are you back up again? Yes. I need to call this the Adam Lane meeting, okay?
Seems like it every time.
Yeah, okay.
Oh. Doesn't look like it's coming up. What's that? Yeah. Okay. All right. So the first contract I am presenting is a contract with H.J. Russell. H.J. Russell is doing our temporary parking right now. They are the builder for that, design build service. In last October, we presented the first work package for $13.2 million. This is the final work remaining to be procured package for another $730,000, which brings their full guaranteed maximum price to $13.9 million. I previously mentioned what was occurring with the temporary parking, and we'd like for the board to approve these funds.
Okay, are there any questions for Adam? Okay.
Yes, sir.
It's 7:30 completes the package, the financing package.
Yeah, it's the remaining work to be procured, and they have done that now.
Okay. So then the 13,946.
That's now, again, that's not total project cost. Of course, there's architectural fees and
Yeah,
a number of
right.
other things, but this is the contractor's total project cost.
Okay. Move approval.
All right, it's been moved by Ralph. By Zim, okay. All those in favor of approval of the design bill amendment signify by saying aye.
Aye.
Those opposed by nay. Motion passes unanimous. Okay.
Okay, the second item on the list is for Covalis. The board may recall Covalis is our medical equipment procurement team. They are the team for the entire enterprise master facility plan program. By project, I will be bringing service orders again by project for medical equipment for each project. This first service order for $2.59 million is for the procurement of the medical equipment for the Southwest Medical Home.
Okay. Are there any questions of Adam on this one? Okay.
This is consultation and procurement of the equipment.
That's correct. And we go through the Vizient pricing, Covalis's pricing, and we have Agility on board as our medical equipment biomed manager. So we have three sources for reviewing and receiving the lowest cost price on every single item. So Covalis bids for us as opposed to us procuring individual pieces of equipment and individual components. I don't think the board would be very happy with me coming with each and
No, I
every
don't think
single
so.
contract
It's
for
not
that.
necessary. We would need 10 more days.
Yes.
But, so, do they have access to our Vizient pricing
They do.
to compare to their pricing?
Yes, and they have access to Agility's pricing, which
Okay.
is significant as well.
And this is procurement and installation?
Yes.
Okay.
So they also coordinate with the contractor, all the components, electrical, Gauss fields, all of that for construction.
Okay.
Okay. I need one. Okay, it's been moved by Roger,
Second.
second by Ralph. If there are no other questions, then all those in favor of approval of the contract signify by saying aye.
All right.
Those opposed by nay. Motion passes unanimous. Adam, I think you are still here.
Yes, ma'am. The third one is for the first tranche of the Jacobs engineering contract. The board may remember Jacobs was one of one that the board approved as qualified to design the central energy plant. The commissioners also interviewed them and approved them. This first tranche of funds is for schematic design only. So I will be coming back for design development and construction documents. The reason we're breaking this up as we have with the past, again, is to develop a full scope of the project so that we can go out for a pricing exercise and then get to a number that we can bring back to you for full scope of services for Jacob, as well as what we will bring out with the CMAR eventually when we have the CMAR aboard.
Okay. Are there any questions, Vanna?
I'm assuming Trent's seen all these?
Yes, he has.
Okay.
Yes.
Because he's really got his head wrapped around that cogen plant, so I'll move approval.
All right.
Second.
Okay. Roger, I got to back out. The motion need to come from the members on
Oh,
the
the fine,
committee.
oh.
Okay. So, thank you, Zim. Okay. Okay. All those in favor signify by saying aye.
Aye.
Aye. Motion passes. I think if y'all are wondering who's on the board, Zim, I'm on the board, Ralph, Dr. Miles, and I can't see your name down there. Okay. Okay, yeah. Thank you. Okay. All right. That motion, all those in favor signify by saying aye. All right. Motion passes unanimous. Okay.
Thank you very much.
You done? Okay.
Yes, ma'am.
All right. Yes. Ashley? Uh-huh. Good morning.
Bringing before you renewal of two contracts, the first of which is a one-year extension to an existing five-year contract with Cigna Health and Life Insurance Company for continuation of administrative services of our health benefits. Total cost is $62.9 million. Again, this is a one-year extension of an existing contract with a negotiated contractual savings of $865,000, with the acknowledgement that we will actually go to market with an RFP for new benefits for fiscal year 2025.
Okay. Are there any questions of Ashley?
Yes.
Uh.
I have a question, actually. Is this for the plan year starting October 1, 2023?
So our plan year is on a calendar year, and so it will actually be for January 1,
January 1.
2024. Yes.
And this is for the health plan only, or is it for other benefit plans?
So it is our health.
It's just the health?
Are there any other questions? Then I'll move approval of this contract for the amendment.
Move approval.
Okay. All right. I beg your pardon? Yes, she did. That's the second one that we were doing, okay. This is the amendment 3 for the,
I'm sorry, I flipped them.
okay? All right. It's been motion and second. All those in favor signify by saying aye. Aye. Motion passes unanimous. Oh, wait a minute. Are there any nays? Motion passes unanimous. Okay, now which one am I on now?
Max Plus.
Okay. All right.
Similarly, I'm bringing a one-year contract extension with Maxor Plus LTD, which is our pharmacy benefit management service, for a one-year extension to an existing contract. And we have a negotiated flat fee reduction of $514,000. This will be for pharmacy benefits for our employees, and similarly, we will go to market with an RFP in 2025.
Okay. Are there any questions of Ashley on this one? No questions. I'll entertain a motion for approval.
Move approval.
All right, had a motion, second. All those in favor signify by saying aye.
Aye.
And those, that was I have no nays. Did I miss something?
No, I was trying to get the second.
Okay, you got it, all right. Okay, all right, motion passes unanimous. All right, I am now to item G, okay? Okay.
Yes, it's in the red folder.
All right, for some reason, they took my red folder. Okay, all right, thank you. Okay.
Good morning, members, and thank you for your time. I'm asking for you to consider approval of a contract between Tarrant County MHMR and Tarrant County Hospital District. The cost of the contract is $1.594 million for a one-year term, which is included in the approved operational budget. This is aligned with our strategic plan for expanding access to behavioral health services in the community. It does assist funding for MHMR for countywide behavioral health services, as well as services for intellectual disabilities. If they do not spend all of the money, unencumber any monies, then those dollars are sent back to us. This does, again, align with our plan to improve patient outcomes and increase access to behavioral health and intellectual disability services, and it does carry a 30-day out clause with written notice. And in particular, Blake, you're still new. I still consider you somewhat new. it's broken down to various entities that MHMR runs in the community, operates in the community, and it allows an access point for patients that we discharge from JPS to be able to utilize some of those services, such as residential detox treatment, adult mental health peer support in the community, children's services, and the intellectual and developmental disability day rehab programs that MHMR runs in the community, as well as behavioral health crisis services. So it's broken up into various entities.
Okay. Are there any questions? All right, then. Sam?
Second.
All right, it's been moved by Zim, second by Ralph. All those in favor signify by saying aye.
Aye.
Those opposed by nay. Motion passes unanimous, okay?
Thank you for your time and consideration.
Okay. We will be tabling H. That will come back to the full board, okay? There is, we are tabling under the next section, number 1, that's being tabled. That was for our executive session, so I don't have a.
Correct, you asked me to bring
Yeah,
that one.
bring that back, okay?
We do not have a closed session.
We do not have a closed session item. So, there being no further business, then I will entertain a motion for adjournment. All right.